Balls Deep.
Welcome to Balls Deep, a humorous yet informative medical show with a mission of optimizing your performance in the bedroom, the bathroom, and the boardroom. I'm your host, Dr. Joe Pazona, a board-certified urologist and CEO of Pazona MD. We hope you enjoy. Now, let's jump right in. Hello, and welcome to another episode of Balls Deep. Dr. Joe Pazona here as always with Kat Williams.
Hi.
Good afternoon. How are we doing today?
Well, I'll be honest, I was rushed to get here today, and I am ill-prepared.
You look great.
Thanks. Well, some of us thought that podcasting was of the utmost importance, and some of us thought that finishing our hair was of importance number one, and one of us lost. That would be me.
I guess 2 hours wasn't enough to get ready. So,
'Twas not, friends. 'Twas not.
Anyhow, I'll choose my battles. Kat, what are we talking about today?
In urology, let's continue our conversation on overactive bladder, but let's talk about some of the treatment options that are out there for overactive bladder.
Yeah, I think it makes sense to, we probably left a lot of people intrigued and going, all right, great. I do all these things. What
I think I have this. What can we do?
Right. What can you actually do about it? Why'd you go to school to tell me not to drink a lot of coffee? So yeah, I think we've got some cool things we're going to talk about today. As a surgeon, I always like geeking out over the cool toys and procedures we get to do.
He's such a geek.
So, well, hey, nerds rule. So
They do.
All right. Well, in that case, let's jump right into the main part of our show we like to call
Balls Deep.
Okay, so treatment options, overactive bladder, medications, what do we got?
Yeah. So, again, as a review for those who didn't tune into the first episode on overactive bladder, remember we're talking about people who are urinating more than every 2 hours with urgency that's bothersome and potentially leads to leakage and waking up several times a night to go to the bathroom. And we are now beyond I've changed my diet, I've lost some weight, I've treated constipation, I've limited my coffee. Like, I still need help. What do we do? So we'll call all those things first line therapy. And it's really how we should approach medicine, right? Treat the root causes, do some lifestyle things before we start pushing pills. But this is one of those cases where pills do play a role. So there are a number of overactive bladder medicines that are on the market. I am certainly not a big believer in pushing pills, but again, this is something where these can actually make huge differences in people's lives. So there's too many to list for the sake of the show here, and but some of the more common ones you'll hear about: oxybutynin, name brand Ditropan, tolterodine or Detrol. These are the class of drugs that we'll call anticholinergics. So that just describes the mechanism in which they work, and they were really the stalwarts of OAB medication for many, many years. It was the only drug class we had. And the problem was these medicines can have some pretty wicked side effects. So,
Well, that doesn't sound good.
yeah, it's certainly, if you look at the long-term compliance of a lot of these medications, it's probably about 30 to 40% of people can stay on these medicines for a year. So
That's not very much, and that's because of bad side effects.
It is. And so the way they're working is they're working on the innervation of the bladder. They're telling the bladder to store more. So anticholinergic, it's stopping what's called the parasympathetic side of our nervous system. Well, what are some of the side effects when we do that? Dry eyes, dry mouth, and constipation. So we're not only slowing down the bladder, we're slowing down other parts of our body, such as salivation, tears, and having BMs.
That's not great.
So people tolerate these medicines to varying degrees. They're sort of a necessary evil that we've had to go to. And for a while, it's just like, all right, here's this pill. And if this doesn't work, good luck. And, for some people, it works great. In recent years, there's a new class of drugs called beta-3 agonists. So if we remember way back to our physiology days, if you ever took that,
Some of us did not.
we've got the parasympathetic nervous system, but we also have what's called the sympathetic nervous system. So that's the flight or fight side of things. Adrenaline or epinephrine activates that one. And if we stimulate that system, then also the bladder will hold more. And it kind of makes sense. If you got a tiger in front of you, you don't want your bladder emptying, right? And so these beta-3 agonists work on the beta-3 receptor of the bladder, and they stimulate it and have the same effect. The difference is because they're not on the parasympathetic side of the nervous system, they don't impact your bowel movements quite as much, and they don't cause the dry mouth and the dry eyes. The two most common ones there are name brands are Gemtesa and Myrbetriq. So these are the new kids on the block. I find that they're better tolerated for people. Their main side effects are changes in blood pressure. So if you have high blood pressure, you got to be a little bit mindful of being on these medications. But for the most part, they're well tolerated. So what's the catch? They're expensive. And like any, new drug, these drug companies, and I have mixed feelings about the pharmaceutical industry. It would probably be a great podcast episode.
I think we all have mixed feelings, or not mixed feelings about it.
Well, listen.
We have negative feelings.
Listen, I'm all for innovation, and there's some life-saving drugs. And you put someone, I've put some women on these medications, and they go, "Oh my God! I have my life back again." You can't underestimate that. And if you look at, the average cost of bringing a drug from discovery to market,
is not cheap.
it's about $1 billion
Wow.
with a B.
Wow.
And so they got to make money. And unfortunately, who pays? It's you, the patients.
We do.
And so, these medicines can cost $400 or $500 a month, depending upon your drug coverage or whether or not it's covered by your plan.
Do these come in generic? Or
They
they're not
don't
yet?
They don't yet.
Okay,
So
good to know.
every medication that comes through the FDA process, the pharmaceutical company has a patent that typically starts from when they first file it. And so it's a race against the clock, depending upon how long it took them to get to market. And so that's why some drugs, you may notice like, wow, that went generic like really fast. And others like, oh my God, this stuff is still name brand. This is ridiculous. So that varies from drug to drug. But the bottom line is we do have overactive bladder medications. We should be mindful using these, especially in elderly folks, because polypharmacy, which is, again, fancy doctor term for you take a lot of pills, is a real issue. And so you think about, people having high blood pressure already. We don't want to worsen that. And then we also see that some of those anticholinergic medicines in people who are elderly can cause some cognitive issues as well. So they can have a little bit of issues with lucidity and getting confused. So, again, the medicines, if they work and you can afford them, great. But for a lot of people, it's not the solution.
Okay, so there are these medications, but I have also heard that there is Botox for the bladder. Is this a thing?
Well, I haven't seen you get this excited about something, Catherine, because of
Botox
Botox.
is exciting. I think all of my lady friends out there will agree with me. Botox is exciting. Is that a thing? Did I make this up? Botox for the bladder.
No, it absolutely is a thing. And no, we cannot save a little bit to inject here or here.
That
ladies.
feels wrong.
So
Okay.
please stop asking me. You do not want me with a needle by your face.
No, I don't.
So why does that make sense? Okay, so if we go back to what Botox does, so Botox or botulinum toxin is taking the toxin from the bacteria that causes botulism. So we all heard those scary stories for us kids in the 80s of kids dying of botulism because of, bad honey. And so how did people die from botulism? Well, they stopped breathing. And that's because it paralyzed muscles. So what we've done is we were able to harvest the toxin, right, and create it in a sterile and synthetic fashion. And the way it works for cosmetics is it's paralyzing muscles. So that's why when someone gets way too much Botox, they can't smile, they can't raise their eyebrows, but it also gets rid of the wrinkles because it's tightening things up. Well, in this case, we're not trying to paralyze facial muscles. We want to paralyze the bladder muscle. So either in the office or in an outpatient surgery setting, a little 5-minute procedure under either local or anesthesia or some light sedation. We go in with a little scope and we inject Botox into about 20 different spots into the bladder muscle. And because the bladder muscle is made up of different fibers that are kind of weaving in different directions, the whole thing usually doesn't get paralyzed, but it slows down the bladder.
It's just enough to slow it down.
So it takes about 5 minutes. Now, like other Botox, one of the downsides is it wears off. So
how often do you have to redo that? Because in your face, we're all redoing Botox every 3 to 4 months.
Yeah, so I'd say for the initial bladder injection, some people can get about 3 to 6 months out of it. With continued usage, you don't build up a tolerance. It sort of almost builds up in the system, and it can last upwards of 6 to 9 months. So that's one of the downsides to it. One of the other downsides is it can, in about 7% of people, work too well, and they can't empty their bladder. And so that would be called urinary retention, and that means wearing a catheter. So the good news is it's only 7% of people, but those 7%, the average catheter time is about 2 months. So I counsel everybody, hey, there's a 93% chance that you're going to be just fine and that this is going to work well, but are you comfortable with the idea of a temporary catheter if your bladder's not emptying well?
And that's a very good question, because 2 months of a catheter might not be the most fun.
No. Now, granted, you're not urinating anymore and having to deal with the overactive bladder. So it all depends on, where you are in your stage of life, So if some people go, well, I'll take that risk over, wetting myself and waking up 4 or 5 times a night to go to the bathroom.
And you can't take the leftover Botox and use that just right up here?
No, Catherine. No.
Okay. All right. Well, moving on. Just wanted to make sure for the 900th time I've asked that question. But I think there's one more thing that I've heard you talk about as a mitigation strategy for overactive bladder. Something about a bladder pacemaker. Can you talk about that? Explain that?
So if we go back again to kind of how the bladder works in the anatomy, as the bladder fills up with urine, nerve fibers are then sending a signal up the spinal cord to the brain and tells the brain, hey, we're filling with urine. You should probably go to the bathroom. To the, oh my God, I really got to go. And so we believe that one of the reasons you get an overactive bladder is that the brain and the bladder are no longer communicating well. It's like a marriage that has gone down the wrong lane, and you're just not communicating well.
Or one person's talking and the other person is not hearing them. Is this a good analogy or no?
Absolutely.
Maybe.
Sure. Maybe. I got to be careful what I say here.
I'm kidding.
But the bladder and the brain aren't on speaking terms very well. So now the bladder, again, instead of giving that gentle signal, screams to the brain, go right now or I'm going to wet yourself. And now all of a sudden you've had an accident. And so if we can stimulate the nerves going to the bladder, it somehow is almost like turning your computer on and off. It just resets the circuitry and it gets it back in that sort of normal rhythm and communication pathway. And so there's a number of ways that we can achieve this, and there's even new ones out on the horizon. So there's actually one you may have never heard me talk about. This sounds absolutely insane, but hear me out. You can actually do a little acupuncture needle kind of alongside the inside of someone's heel bone. And there's a nerve called the posterior tibial nerve that runs all the way up and connects to the same nerve root as the bladder. And
I've never heard you talk about this. From your heel bone?
it's crazy, right? And so if you
Weird.
stimulate that nerve, it is going up and somehow also kind of resetting that circuitry.
Okay.
It's not something I do a lot of because you've got to do it weekly over 12 weeks. And so I think it's a really great option, say, if you're in a nursing home or you're just really not fit for surgery. Like we just don't want to do anything under anesthesia whatsoever. It's a great option. It actually works, and it can last up to 6 months. So crazy to think, right? Like a little stimulation of a nerve in your ankle can lead to bladder improving. Now, what we more often do, because most people can get through this, is we actually go through the back. So if we think again about the back of the bony pelvis, we've got, the tailbone that we're all kind of sitting on. We all know that, that we've all hit a tailbone before. Mm-hmm. But the tailbone is coming off what's called the sacrum. And the sacrum is the part of the middle part of the pelvis where there are actually holes in the bony structure where nerves are coming out of. And don't ask me who or why. I don't know the origin story, but someone got the crazy idea of putting a little needle and an electrode next to the third sacral nerve root. So there's 4 spots, go 3 down.
It's really specific.
And place this little wire electrode, connect it to an external battery device, and stimulate the bladder, and within a week can be changing people's lives. So that procedure is called sacral neuromodulation. So if we break that down for the Greek and the Latin root people in the room, sacral, so we're going through the sacrum. Neuro means nerve, and modulate means to change. We're going to change the nerve of the sacrum. And by doing so, again, it sort of is that circuitry reset that we can do between the bladder and the brain. So the way we do that procedure is actually in my office. It's pretty slick. I mean, I did one the other day. It was 5 minutes. And what we do is someone comes in, they lay on their stomach. We use kind of anatomic landmarks. I feel for where the tailbone is, and I kind of measure up a certain amount and a certain amount to the side, inject some numbing medicine, and then I place a needle until I feel it drop into that little hole, and then we stimulate it. And when you stimulate that nerve, someone's, lack of a better term, their butthole, their anus contracts.
Elegant.
Contracts involuntarily. We have all, people talk of different terms. So, and it also stimulates their big toe. So
their toe.
So when you stimulate this nerve, you see it's called an anal wink.
So your hiney and your toe are connected?
Yep.
This is I don't want to do this show anymore. It's too weird. It's too weird.
This is the cool part.
I'm kidding.
How neat is that? That's the way our human body works, right? And so we see that little anal wink and the toe goes. And so the representative from the company goes, all right, we're there. And we do that on both sides. We put in these tiny little wires. I mean, they're about as fine
They're
as...
inside your body.
Yeah, temporarily. So they're about as fine as... So your necklace, the chain you're wearing...
which is really, really thin.
Exactly. And so we put those in. We don't even suture it in. There's no incision. We put a bunch of tape. We connect it to a little external kind of mouse cord battery device.
Remote control?
Yes.
Kind of?
Yes, 100%.
Okay, I made that up. I didn't know that.
Yeah. And we then see them back a week later. So again, no cuts, no incisions. I jokingly tell people, I can't hurt anything if I tried with this procedure. The spinal cord is nowhere near this area. We're going in with small needles. Honestly, you have a higher rate of a complication getting an IV in your arm than doing this trial procedure in my office. And then a week later, people come back and, we talked to previous episode about that voiding diary or bladder journal. And usually they've got a huge smile on their face and they want to hug and kiss us because they're like, oh my God, this has changed
everything.
My life. I slept through the night. I used to soak 3 to 4 pads a day. I was wearing diapers. I had a normal life for a week.
Wow.
And I mean, it gives me chills just thinking about it. Like, this is why I went into medicine. Like, to be able to offer a cure that is safe and changes somebody's life. Like, I don't know if there's a surgery or a procedure that I offer that makes that big of an impact with so many pros and so little cons.
Is there anyone that this is not appropriate for? It seems like such an amazing thing. Who would this not be appropriate for?
It's a great question. So this is not going to be your treatment if you're a guy who pees too much because you got an enlarged prostate. Okay. So this is where it's so important to get a thorough evaluation by a urologist who listens to you and a team that does a thorough evaluation, because I've seen these things thrown in people who just drink too much coffee.
And they didn't need anything.
Or a bad diabetes.
Okay.
Or who woke up twice at night in their 80s and they woke up once one night and they think they could put the implant in, and then they come back to me and they're like, I still wake up 2 times a night. I'm like,
But that could be normal. That
that's
could be
normal.
quite normal.
Yeah, I mean, that's
And you
normal in your 80s. And why did they put you through that?
got
So,
it.
it's more a matter of just properly selecting people. The most important step of surgery and surgical training is deciding when not to do something.
Well said.
We've got to look at healthcare in ways in which we're not just pushing pills and surgeries and then next, we're not a puppy mill. So the main people it's not for are people who are not properly selected. Now, we also want to be very mindful that if you have, say, a spinal cord injury, so there's a huge population of folks out there who really suffer and struggle with bladder issues because they have bad MS. They've had a spinal cord injury from a car accident. They were born with spina bifida. This is probably not the procedure for you because you have to have functioning nerves. So we're not regenerating nerves, unfortunately. If the nerves below a certain injury or level of injury of a spinal cord are there and are damaged, this is not going to help you.
Okay.
So for the most part, most people are candidates. Now, the other one of the other caveats is to qualify, you have to technically fail 2 medications. So again, although I'm not a big pill pusher, I have to walk people through this and say, listen, I'm sorry, insurance will not cover this unless we check these boxes that these pills don't work or you can't tolerate them. So that's a big thing. And then lastly, you got to have severe enough symptoms because when we do that trial period, we need to document at least a 50% improvement in your symptoms. So if you're just someone who's irritated because you wake up twice at night to go to the bathroom, I got to pretty much get you sleeping through the night or this ain't going to work for you. So we've got to weigh out how much of this is just reasonable and mild, even though it may bother you, versus you got to have more moderate to severe symptoms. So, we're not throwing implants in all these people.
Well, that makes a lot of sense.
Yeah.
Okay, so what I've heard today is 3 very good systems of treatment options for overactive bladder. What else do we need to know? Or did we cover it?
Yeah, I think the last thing to know about the nerve stimulator is twofold. Number one, once we do that trial period, if it's successful, we are then going to move into a full implantation. So I don't want people leaving here thinking you're wearing these wires out of your back the rest of your life. A week later, we pull out those little wires and no one can tell we've done anything. Mm-hmm. But if you did well, which is about 70+% of people, we're going to take you to the operating room and we're going to implant a tiny little stimulator. They're about the size of those like little USB jump drives that you put files on a computer.
Right.
So they're that small now. They're now making ones that are rechargeable, that you recharge every 6 months by putting a waistband on while you're watching TV.
Wow,
and these devices
bizarre.
are now lasting 15 to 20 plus years.
Oh, years.
Years. So the likelihood of needing sort of a new pacemaker put in is becoming really, really low. So, that is that's something that's important to know. And then there's new devices on the market. I mean, there's now a little coin you implant near someone's ankle, again, stimulating that nerve. They're looking at stimulators that are placed near the vagina or bladder. So it's an exciting technology. And then something I probably won't have a full episode on, so I'll just mention. So interestingly, we also utilize this for what's called fecal incontinence. So we want to talk about something that is never talked about.
Right.
No one raises their hand and says, I pooped my pants. But there are people out there suffering, and you really shouldn't.
Pretty terrible situation.
This works even better for that. So that's the good news.
It works for that as well.
Absolutely. So again,
Wow.
we do a thorough evaluation with some GI doctors and make sure we're not missing something else. But for the most part, if you have loss of control of stools, this is an amazing therapy. Secondly, and this is fascinating, this can also help people who can't urinate.
At all.
So the same therapy that helps an overactive bladder can help an underactive bladder. Now, the important parts are, again, this is not for a man with an enlarged prostate whose bladder wall is completely shot. It is not for women who were teachers or nurses and stretched their bladder out. It's for those rare cases where a man or a woman has some nerve issue, but all the nerves are still functioning and they just can't empty their bladder. It can actually help that. So Really cool therapy, but I think the key points are minimally invasive and safe to do.
Okay. Well, that's a lot of great hope for anyone out there suffering from the symptoms of an overactive bladder.
Absolutely.
Okay. Well, I want to wrap up this segment in my favorite segment of the show. Just the tip. So what do we learn today? Treatments for overactive bladder. Number one, medications should be the second line therapies, but are often expensive and have some bothersome side effects. The first line therapies obviously being your lifestyle changes. Mm-hmm. Number two, Botox isn't just for your face. It can slow down your bladder. And your husband won't give it to you in your face if he's a urologist, which I still think he should try. And the third is a bladder pacemaker can cure your overactive bladder, and it's a lot easier than you think.
Yeah, it's this is an exciting side of medicine and what I do. And I'll say it again, some of the happiest patients have come in to see one of our awesome providers at Pazona MD, have had that evaluation and have kind of been walked through that sort of pathway. And if they needed that therapy, it is a game changer. I mean, it really is, and it really couldn't be easier. So I hope that we built some awareness about this. I hope most of you have listened to the first episode and solved your own problems. I mean, the best doctor visit is no visit. And that's the purpose of this show, is to build awareness and to give you some tools to improve your own health. But when you're at that point, you need that trusted guide. We would love to be that. So,
and if you need Botox in your face, call your dermatologist.
Yes, go elsewhere. So on that note, Kat, thanks for a lovely episode. And thank you, Stream Team, for listening in once again. Please subscribe on your favorite podcast platform and YouTube. And until next time, please show yourself a little more love and grace. We're all works in progress, and that gives us opportunity to grow and improve. Thanks, and have an awesome day.
Thank you for listening to this week's episode of Balls Deep. If you'd like to join our Stream team of listeners, please click the subscribe button on your favorite podcast platform. For more information about our practice, Pazona MD, please visit pazonamd.com. This podcast is for informational purposes only, and the content is not intended to be a substitute for professional medical advice. The show does not constitute the practice of medicine. No doctor-patient relationship is formed through this podcast or any of the social media channels related to this show. The use of this information is at the user's own risk. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.